about what does nearsightedness mean to you? And that poll will be it's in the chat. So we welcome you to do that as we wait to have other folks join us.
Thank you,
And I
Carol.
asked, and as the word cloud gets populated, I asked the panelists to help me in a conversation about, the words and to just encourage participation.
Thank
I'll
you,
be back
Carol.
at 12 o'clock.
So we have our question is what challenges do children face when they can't see clearly? And my name is Chris Hall. I'm the director for the Center for Excellence, Center to Advance Interprofessional Education and Practice. Boy, I have had almost too much coffee today. And I invite you to participate in the word cloud by either opening Poll Everywhere on your phone if you already have the app downloaded, or you can open a new tab in your browser and navigate to pollev.com/UNE CAIEP, or you can text it. And this information will remain on the screen when we move to the word cloud. And you can see that if you have a response that is 2 words, then if you connect them with an underscore, they'll stay together in the word cloud. So let's go ahead and have a look at what's happening. Can everyone see that visual? I'll take an affirmative if anybody, I can't really see everyone.
Yeah, it shows.
Okay, thank you, Jennifer. And so what are we seeing here?
Impediments, rejected insecurity.
I see that social is quite large. And so there's so many elements to how that impacts a child with social insecurity, social anxiety.
And if they wear glasses, all around, having to wear glasses when you're that young.
Yep.
I see depression also, and so there's that aspect to it. Disassociated, makes it hard to learn, hard to participate. Amy and Crystal, are these the kinds of things that you're coping with in the clinic when you're helping children with their vision?
Yes, these are all right on. I mean, I think we're set up nicely for our lecture.
Yeah.
And I know that your community clinic deals with disparities. Can you talk a little bit about how that impacts your customers and their families?
Right. One of the memories I have from early on in my career was a 3-year-old, or not a 3-year-old, she was about 5 years old from another country, first eye exam in our clinic, and she had very high nearsightedness. And when we put on her first pair of glasses, her world just changed. The smile on her face, like, oh, this is what the world is supposed to look like. It's just so telling, and I've always been struck by that impact. So her confidence would increase, and her ability to learn in the academic environment just exponentially grew.
That's a great story. Thanks for telling that. I can remember when I got my first pair of glasses, I tried on someone else's, and I realized that you could see each individual leaf on a tree.
Yes.
Blew my mind.
Right.
So thank you for that lovely conversation. And I just want to welcome everyone and remind you that we will get started at 12:05. So we're allowing, folks to get settled. And as you are coming in, please complete there is a survey link in the chat where you can answer the question, what does nearsightedness mean to you? And Chris, you can tell us how to get to the chat again for those who just arrived who may not have heard it before.
Yeah, thank you, Carol. So I'm Chris Hall. I'm the director here in CAIEP. And you can either open up Poll Everywhere on your phone if you have downloaded the app, or you can navigate to open up another browser and use that join by web indication at the top of your screen, or you can join by text. You can put in up to 3 answers into the word cloud. And if you want your 2 words to hang together, go ahead and put an underscore in between them and they will hold together.
Thank you, Chris. And I can see that it's filling up really nicely. So thank you for participating in this fun activity. And do we want to talk about some of these new, it's going so fast, it's hard to.
Anxiety's been holding strong, or did that shift from another one?
I think
Can't remember now
anxiety
so many
has
words
taken
at this
over
point.
from social.
Yes, because social was yes, I think
Yeah.
anxiety definitely has.
And that can affect so many things.
Absolutely.
Yes.
And so I see connection there, and I'm interested in that, the follow-on impacts of lacking perhaps connection because you person. I'm glad to see equity and
It's rejected, you know,
Mhm.
it's into that. Yes, being so young and being different, you know.
Carol, I'm having a little trouble hearing you. I don't know, this wasn't happening before we started. You may need to
Oh,
get a little
I haven't
closer.
moved. Are you hearing me better now? Maybe I just need to speak up. Are you hearing me better now?
That's better. Yeah, thank
Okay,
you.
I will speak up.
Don't be shy. Uh, Confusion for
Yeah.
sure.
So I'm gonna start a formal, event. So equity, I think we've seen it, the class. And I'm sure that's probably with the classroom, which is all tied to social anxieties, all of those. This is really wonderful. This is really wonderful. And thank you all for participating.
Yeah.
This really sets us up
I'm
nicely for
curious
a
about
conversation.
friendship. Yeah.
Go ahead.
About which one, Jennifer?
Oh, no, I was curious about friendship. I don't know if it was attached to something else, but I wonder.
Okay.
Yeah.
Your friends are the ones that don't make fun of you because you have glasses.
Exactly.
Right.
And it's now 12:05, so
Yep. So
welcome everyone to the Center to Advance Interprofessional Education and Practice Knowledge Exchange today. It's titled Screens Down, Eyes Up, Understanding the Myopia Epidemic and Reshaping Care. This knowledge exchange was designed in collaboration with the New England College of Optometry and the UNE Masters of Public Health program. We would like to welcome University of New England students. It's great to see so many professions represented. I see public health, dental hygiene, pharmacy, OMS, psychology, COM, and if I missed your program, welcome. We would like to welcome community members, prospective students, alumni, and students from other universities who are with us today. We are so glad you're joining us. My name is Carol Ewan White, and I'm the Director of the Graduate Programs in Public Health here at the University of New England. And in that program, you can complete your MPH or a graduate certificate online. I will be your host today as we explore the roles that public health providers play in recognizing myopia or nearsightedness as a global public health challenge, and we look at ways to work together to slow its progression and protect the sight of those who are affected and prevent others from being affected for years to come. And we look at this on a local, state, and national level. I hope you will continue to participate with it from a place of curiosity and compassion as we learn together about interprofessional approaches to shaping vision care. Near the end of the event, we will share a survey link that will capture student attendance and community participation. Please let us know how we did by completing that survey. We really want to know how we did so we can improve. Now you will see in a moment the learning objectives. Well, they are right there. These are the learning objectives, and they'll also be in the chat. And as you participate today, be sure to listen for ways that you can plan to incorporate some of what you learn into your future practice. Now I will ask our panelists to introduce themselves briefly, starting with Amy.
Hello, everyone. My name is Amy Moy, and I am the person who oversees our relationships with community health centers at the New England College of Optometry, where we partner in sending out our faculty and our students to provide eye care in much needed areas. I also oversee our interprofessional education program at NECO, and hopefully some of our NECO students are here listening today. I'll turn it over to Dr. Lewandowski.
Hi, everybody. I'm Crystal Lewandowski. I'm an associate professor of clinical optometry at the New England College of Optometry. I'm also the director of vision services at North End Waterfront Health. We are a community health center located here in Boston, Massachusetts. Jennifer?
Hello, everyone. My name is Jennifer Said. I am an assistant teaching professor in the Master of Public Health program at UNE, working alongside Carol. I focus on the workforce development along with curriculum and assessment. And I'll pass it back to her. Thank you. Welcome.
Thank you. Thank you, Jennifer. Before I hand over to Amy for the presentation, I want to briefly share my story. So picture this: a bright young Jamaican girl who loves to read. She would read at all hours, including during the night with less than perfect lighting. All this reading and studying resulted in this girl starting high school at 10 years old. But at 11 years old, she was diagnosed with myopia and started having to wear glasses. That young girl was me. So fast forward to the present. I have a daughter with worse myopia than mine. And you'll hear a little about that and why that is not strange as you learn more about this topic. So as you can see, this topic is close to my heart, and I'm honored to be here today to help highlight its importance. We will explore this case more in the breakout session. So let's now move on to the presentation. So over to you, Amy.
Thank you so much, Carol. So let's set the foundation here and explain what is myopia. Myopia is often called nearsightedness, and it used to be just seen as, okay, you get glasses and you're fine. What we're learning now is that the prevalence of myopia has greatly increased around the world. And myopia affects learning, your quality of life, and your long-term vision. In fact, it can affect your retina, which I'll tell you in a second more about. It has public health implications beyond optometry. You can see in this diagram this green tomato, and if your eyeball is perfectly round and has no prescription in your glasses, the the optics of the tomato will end up right on the back of the eye. However, when in myopia, your eyeball grows longer, and so the optics will make the green tomato focus in front of your eye. And that's what glasses correct. They correct the light bending through to make the tomato focus on the part of the eye where it's clear. And so this eyeball elongation is part of the problem that we'll talk about in the next slide. Myopia makes your eyeball longer, and therefore there's some stretching that goes on for your eyeball. And you'll see the inner lining of the eye is the retina, and that can actually detach if it gets too thin. You can also have problems where the center of your vision is in your retina, and you can be more at risk for glaucoma and cataracts. So the higher the prescription that you have for myopia, the higher your risk for vision loss. And if we prevent the myopia from progressing too much in childhood, we can prevent that risk for later vision loss later in life. So to explain the epidemiology and why we're calling it an epidemic, if you look at this graph and first pay attention to the blue bars, the vertical blue bars, you can see in the year 2000, the overall prevalence went from 22.9% and then projects to 49.8% in the year 2050, where basically half of the global population will have myopia. And that's a big jump, right? And we've also seen that there's certain areas of the world that have higher prevalence. And so you can see the top bars are actually countries in Asia and North America. This also speaks to urban versus rural differences and intensity of education among different parts of the world. I'll turn this over to Dr. Lewandowski.
So Dr. Moy just described the anatomical mechanism of why myopia occurs, and now I'm going to talk a little bit about some of the main drivers of myopia or how it occurs. So let's start with genetics. To put it simply, a child's risk of developing myopia increases if one or both of the parents are myopic. So when both parents have myopia and wear glasses for myopia, there's about a 50% chance that their child will become myopic. If only one parent has myopia, there's about a 1 in 3 chance that the child will develop myopia. And if neither parent is myopic, there's still a 1 in 4 chance that a child will develop myopia. So given what we know about these odds, when we're collecting a case history or family history, we can start to gain information that might be helpful, especially if we have a child in our clinic who's complaining about headaches or squinting or difficulty focusing. Now, some of the other drivers of myopia include external factors, such as low levels of outdoor activity, prolonged near work, such as reading, gaming on portable devices, even reading a book and anything up close within arm's length, and also poor lighting levels, which we mentioned a little bit earlier. So we can think of genetics as setting the foundation or baseline risk for one's eyes, and then these external factors I just mentioned as modulating the outcome. Next slide. So let's talk about myopia and learning a little bit. We know that uncorrected myopia affects reading speed, comprehension, and is linked to poorer school performance. It also can affect a child's self-esteem, engagement in social activities, and sports performance. So many of these things were already mentioned in the poll, so it sounds like many of you have experienced that personally, or at least have known someone who has. And as future healthcare professionals, these things are something we're all going to be helping manage for the rest of our career. So on the right here on the screen, there's an image of a gymnasium that might look a little blurry to you. And this is from the CooperVision visual simulator. We won't go through it, the live simulation today, but if you want to use the QR code, we'll also put a link in the chat here. You can click around and look at what different types of glasses prescriptions may look like for someone who's not wearing their glasses. And in this example shown here, this is an example view of what someone who needs myopia correction of 3.5 diopters. So that's the amount of prescription they need. So you can imagine in a sports setting or in a school setting like this, in a big open gymnasium, if things are blurry for the child, they may not be able to see a ball coming at them or a signal from across the room. So that could affect their sports performance, their PE class, physical education performance, and some of the social interactions within that setting. And so if they're not doing well, that may cause them to have poor self-esteem, withdraw from the activity completely, and can affect their engagement in those activities. And so this may have cross-disciplinary effects and may show up in some of your offices, such as speech language pathology, nursing, behavioral health, and social work. So some of these children who come in with poor behavioral concerns in school or learning concerns may be a result of uncorrected myopia. I also know there's a lot of dental students here today with us, so certainly not being able to see something coming at you far away could cause some injury too, and some dental concerns. So now we're going to go through what a routine eye exam looks like for a child. And here on the right here, this is actually a picture of Dr. Moy and her daughter Evie in an eye exam. And I'm going to go through some of the different tests we do and some of the different tools we use for a pediatric eye exam. I think one of the common misconceptions I hear among friends, family, and even some healthcare professionals that I interact with is that they don't realize we can do eye exams on young babies or toddlers who don't know their letters. So I'm going to go through some of the tests we do to help assess those children. So first of all, we can check vision with special eye charts that use shapes or letters or numbers or visual gradings or lines. So an example on the bottom right corner of the screen shows some shape symbols that we use to assess vision. And even if the child doesn't want to talk to us or is unable to speak to us, we have extra cards that we can use where the child can point to the shape and match what they're seeing on the distance chart across the room. We also use various lights and lenses to assess refractive error or the need for a glasses prescription. And so again, even if a child doesn't speak to us, they don't want to read the eye chart, or they can't verbalize what they're seeing on the eye chart, we can still use our special lights to determine whether someone needs glasses or not. We also assess 3D or binocular vision with stereopsis testing, as well as color vision. We assess for an eye turn by doing a cover test to look for strabismus. So an eye turn, the eye might be turning in, might be turning up or out, and that can affect a child's vision or ability to read. We also look for amblyopia, which sometimes is referred to as a lazy eye when one eye is not correctable to 20/20, even with glasses. And we look for eye focusing issues. We look at the eye muscles and how the eye muscles move inward so that people can read comfortably, how they converge or how they diverge so people can see comfortably and clearly far away. We, of course, look at the eye health during an exam. We will dilate the pupils to assess the back of the eye. And we also communicate with school nurses, teachers, and other healthcare professionals as appropriate, depending on whatever accommodations may be recommended. So I think it's a good time now to discuss the difference between an optometrist and an ophthalmologist. Just as a refresher to anyone who's already heard this, I like to think of optometrists as the primary eye care providers who are the first healthcare professional who can help assess an eye problem. Whereas an ophthalmologist is a medical doctor for complex eye conditions who often manage complex diseases and perform surgery. Both professionals can manage general eye disease, triage and manage red eyes, new floating spots, any problem-focused visits. And then an optometrist will refer to an ophthalmologist if indicated. Some of the educational differences between the two professions are shown here. An optometrist goes to optometry school for 4 years with an optional 1-year residency, and an ophthalmologist will attend medical school for 4 years and 4 to 5 years of additional residency and fellowship. And so how does an optometrist manage myopia? Well, as Dr. Moy mentioned earlier, it's really crucial that we identify and address myopia early on. So children between the ages of 6 to 12, that's the key time frame for us to address myopia, because that's the key growth phase for eye and vision development. So the earlier we identify it, the earlier we can address it. So what we do is we can prescribe glasses, including specialized lens design to help control the myopia and minimize the progression of myopia. We can also prescribe contact lenses and specialty contact lenses that are specifically designed to reshape the cornea to help minimize myopia progression. Those types of lenses are called orthokeratology lenses. And we can also prescribe medication, eye drops to help manage myopia. And getting outdoors is a big thing that we can all recommend to young children, and we'll talk a little bit more about that shortly. And lastly, the recommended eye exam frequency, I want everyone here to know, is really from birth until we're older. It's recommended that patients come see us for an eye exam pretty much every 1 to 2 years. So again, as I mentioned earlier, from birth to age around 2 or 3, we do recommend someone's first eye exam. From ages 3 to 5, we recommend at least once between 3 to 5 years old. And then during school years, we want to see children annually, and during adulthood, at least every 2 years, and annually after 65. And one thing I'll point out here is these recommendations are for low risk or asymptomatic folks. So anyone with higher risk factors, which you may be managing yourself, may change those recommendations to a more frequent eye exam. And some of those risk factors are listed here. Amy, I'll turn it back to you.
Thank you. So now we realize that you're not all eye doctors, but you do see people with eyeballs, no matter what your profession. And so we wanted to tell you a few ways that this is relevant to you in your profession, and as you see children. And one of the things, there's an acronym called BLINK. And my apologies for the AI created image, but it was the best I could do to bring it all together. So B is for blink. Did you know that when you're staring at screens, you blink 5 to 7 blinks a minute, but normally you're supposed to blink 25 to 30 times a minute? And so we see this all the time with children, especially who have a lot of screen time, and it adds up and they start having symptoms. So we advise that they do the 20/20 rule, which is a guideline. Every 20 minutes, try to look in the distance around 20 feet away, but obviously you don't need to measure it, just look in the distance for 20 seconds, and then you can go back to what you're doing. L is for lubricate, because of all those dry eye symptoms, artificial tears are very helpful. We don't recommend Visine because it has a rebound effect where your eyes just get redder without the drops eventually over time, and there's a rebound effect, and then they get more red than they were before. So you really want a lubricating drop. I is for inches away. We want to keep screens 25 to 30 inches away, and near device, N is for near device breaks, taking a break every 20 minutes, like the 20/20/20 rule. But also, it's very important for kids to get about 2 hours a day of outdoor play. Living in New England, that can be a little harder, but the point is looking at green spaces and not focusing at a near point for hours at a time. That in itself is very helpful. K is for know your sources. TikTok is good for some things, but know that as a health professional, you should be seeking out certain sources like the American Academy of Family Physicians, the American Optometric Association, or the American Academy of Ophthalmology. So as healthcare professionals, you can also watch out for eye turns, frequent squinting, headaches, especially frontal headaches, or eye strain complaints. You might see this play out in schools where the child, after 20 minutes or even 2 minutes of reading, start to say they're bored, they're tired, or their eyes hurt. Declining or low academic performance definitely triggers a need for a visual eye exam. And just having myopia in early years is a sign to consider myopia control, those treatments that Dr. Lewandowski was talking about. Using community resources, so knowing the eye care professionals in your area and having people that you usually go to for referrals is important, and reinforcing the importance of routine visual health care. We know that when kids go to well child visits, they might get a fluoride treatment, and equally, eye care is as important and impactful on their academic and home life. Advocating for children is something you can do even if you're not in eye care. Sometimes they lose or break glasses and don't understand, or the families don't understand that they can get a replacement. Encouraging a baseline eye exam by age 3 can be super important to get them started on the right foot. And then ask children about screen time and reinforce asking them, do you take breaks from the screens, and talking about the blink principles. We all know in the public health arena that health equity matters, and insurance should not be a barrier to eyeglasses. You could do your part to advocate for coverage of vision care in your state, and also know that special assistance programs exist. Community health centers are especially good at knowing how to get free glasses for people. And common barriers might be that the parent's job might not allow them to take too much time off and take their child to the eye exam. There may be transportation challenges. They might have limited health literacy and not understand why glasses are important, or they might need an interpreter to really explain things to them. And again, there might be financial strain and insurance coverage gaps. So pediatric vision care needs greater public awareness. So for the public health students online, thank you for helping us to spread that awareness and also advocating for policies that will protect the visual health of the kids for this next generation. So those are our references. I just want to thank everyone for tuning in and understanding that visual health affects all of us. We all have a story about our vision, or someone we love their vision in some way. And we just really want to collaborate and work together so that we can really protect the next generation from having high myopia and having eye problems down the road. So thanks for listening, and I will turn it over to Jennifer.
Thank you so much for a very informative presentation. Thank you for really showing the effects of the compounding effects of intense learning expectations and also screen time, and how we're realizing that through the data. And thank you, Carol, for kicking us off with your own personal story. So we will be moving into our breakout rooms shortly. So once you're in the breakout room, we do ask that you turn your cameras on if you're able. Introduce yourself, your profession or role in addressing the vision concerns of your patients. And if your breakout room doesn't have a designated facilitator, just start by saying hello and going through the prompts. We do ask that you assign a note taker and who will record your group's takeaways. These notes will be shared in the chat once you return back to the larger room. So you'll have about 10 to 15 minutes for this segment. And you'll be focusing, we're entering there are some prompts to help guide the conversation. You don't have to go through every single prompt. You may focus on one or two, whatever makes sense for the conversation and for the group. And the prompts are: what more do you want to know about this girl that we heard about earlier in the session? What health, developmental, environmental, or social factors could be influencing your myopia or eye strain? How might her age, academic pressure, cultural context, or limited access to care shape both risks and opportunities? What do you need to understand about another health professional's role to work more effectively together? And finally, how can you help to address barriers to eye care? Have fun.
Thank you, Jennifer. And Lee, you can go ahead and open the breakout rooms. those notes in the chat now that you're back. That would be fantastic. Take about another 10 seconds before the breakout rooms are closed completely. If you're just coming back and you were a note taker, please drop your team's comments and thoughts as you captured them into the chat. And Jennifer, I think everyone is back.
Lovely. Welcome back, everyone. I hope you had some really great conversations and got to explore and dig deeper into the case study and the content we learned from Amy and Crystal. So feel free to add our amazing note takers, feel free to add those takeaways into the chat, and Chris will be helping me with sharing some themes that come up. As we're sharing, if there are folks who would like to unmute and offer some notes, that'd be great as well. And we're doing okay with time, I think so.
Yeah. I'd love to
That's a
hear
good
from,
question.
go ahead.
Oh, no, sorry. I shouldn't have said that out loud. I was like, oh, that's a good question. I saw a question pop up in the chat. Okay, go ahead, Chris.
I was just going to say I'd love to hear from Amy or Crystal what you'd covered in your breakout rooms and who you had there.
Sure. My group had Andrew recording for us, and he put it in the chat here. We were wondering why she was reading in the dark, if that was by choice. Was she too busy during the day? Was there not enough light, or was she not supposed to be reading and supposed to be sleeping? And how often was she able to see the eye doctor? Was it hard to get glasses? Things like that could make more barriers for her. We also talked about the long-term effects of her reading night and day and focusing at a near point, and not taking breaks, looking out in the distance, and blinking. And so we worry for her long-term retinal health and hope that she's getting regular eye exams to check for that. Anything else, Andrew? Did I miss anything? Awesome.
Yeah, and our group had some of the similar questions, and we also wanted to know more about the glasses themselves. How old were they? Did they feel heavy and uncomfortable on the face, or did the 12-year-old just not like wearing them, or did they love wearing them? And what I thought was really interesting, and I'm really glad someone pointed this out, is we wanted to talk to the child directly to hear their point of view. We wanted to hear from them, what they felt about their glasses specifically and their vision with and without them.
Jennifer, there's a question in the chat, I think that is common among glasses wearers, in that the perception is that wearing glasses makes your eyes dependent on the glasses. Can Amy or Crystal, can you weigh in on that a little?
You want me to take it? So I have this question a lot where people are thinking that they're dependent on the glasses. And I tell them that it's not really dependence. It's that your brain understands now what a clear view is. Especially when you're in college, it's only going to help you. It's not going to make you worse. It's just that your brain will want that clear image now versus the blurry image you had before. So it won't hurt you more to wear the glasses. You should take the full effect of having clear vision.
I like to use the analogy of wearing shoes. You can choose to wear them or not wear them. It's not going to change the shape of your foot. It's just going to change how comfortably you're walking. You can usually grasp that shoe analogy.
Carol, do you want to weigh in on whether or not you had access to eye care and why you were reading in the dark?
Happy to weigh in. It's that I was reading in the dark for, I think, every reason mentioned there. It was often when I shouldn't be reading because I shouldn't be in bed. And sometimes it was due to having the use of like a lamp, it's not using it's not the proper lighting for the situation. And with regards to access to care, my mom was an early childhood education specialist. So she was, always in tune with your expectations as a child, your development and all of that. So I did have access to the doctor when I said I needed it, because like we talked about too, many times you're not going to admit that you're not seeing right as a child, because you don't want to end up wearing glasses because there's a stigma attached with it and being called four eyes and all of that. So you delay reporting out to your parents or your teacher or your doctor or anyone, any adult, that you may be having some issues with your vision. And I did do that too. So it's a combination of all of these. But I did get the glasses. I saw some questions there. So I did get the glasses, and I was able to get, follow up with the appointments as required and all of that. But after I finally spoke up.
And that's great. In our group, we had a really great discussion about the training that is needed for professionals working with children, that behavioral issues, like leaning into the curiosity of an eye problem instead of, oh, this kid is just bad, especially when we think about different identities in the classroom. And so really making sure that we are all on the same page as the adults in the space, that we're not leaning into, oh, this kid is just a bad kid, and they're being labeled as such. And that really can set the trajectory in a pretty awful way, depending on the climate and where they are. But leaning into the fact that, wow, maybe this is happening because they just can't see. And, not to bring up dyslexia, but that also tends to be something that's missed because of just not being considered as a professional in the room working with children. But we had and anyone from the group want to share anything else about the environment, the advice that we got about outside? And I know Gabriella and let's see, and Angelica were in the group as well. We have 1 more minute.
If not, in the chat, we have a request for advice on compliance. So if you have pediatric patients who are not wearing their glasses, and I think, Jennifer, you got to a little bit of that in your comments, but I wonder if Amy and Crystal, you have any advice about helping peds patients want to wear their glasses to make them maybe fun?
Mm-hmm.
Yeah, we encounter this all the time, and it is age dependent. When my daughter was 3 and needed glasses, we were singing songs about glasses. We're also sometimes saying no iPad unless you wear your glasses. So that's how we got her started. With an older kid who's worried about their image, I like to sit down and just take a minute to ask them, are there other kids in the class who wear glasses? Have you seen this movie star wearing glasses? Some of them are pretty trendy. I think Michelle's right. It's more fashionable these days to wear glasses, and that works for us. Every so often, I still have a parent who breaks down in tears that their child needs glasses. And to me, that's a health literacy issue where they don't understand the benefit for their child, being able to access the academic environment. And so we still have work to do about visual health awareness, but I think that kids, if people spend the time to understand their emotions around it, I think we can get them to a good starting point.
Thank you so much. And we're at time for this segment. I want to thank all of you for being so participatory. I'm sorry, Crystal, did you want to say something? Okay.
I'll put it in the chat.
Okay. But thank you so much for being so engaging. This was a really great conversation, and I would like to pass it over to Carol. Is it right? Is it at this time, or open it up for Q&A, Chris? We have about 4 minutes.
We can end now unless there's more.
Wow, this was really good conversation. And I want to say thank you all for keeping this space, about compassion and curiosity. And as you know, I'm happy to answer all of the questions. That was kind of fun, being the case, the person for the case. So that was fun. So I want to say thank you to everyone for attending today. And please complete the participation survey to tell us how we did, because we as I said at the start, we really love to hear how we did so we can improve, because it's all about giving the best quality service to our students and community. So let us know how we did. And we always, thank you. We are always presenting these events. So please join us next Wednesday, February 11, if you can believe that, from the same 12 to 1 for CAIEP's next presentation. And that one is titled Healthcare Pathways to Safety and Support, Improving Clinical Response to Human Trafficking. So that's a very important topic. It's a hot topic too, with all that's going on in the world right now. And this presentation will feature experts who will take a survivor-centered team approach to identifying and providing trauma-informed care for individuals who have endured human trafficking. The event will be hosted by UNE's Anthropology Associate Professor Alicia Peters, and details will be shared in the chat today, so you can plan to be here next week. We appreciate your attendance today and at all our events. Participation may be applied towards your IP distinction application for the students in the room, which demonstrates team readiness to your future employers. For the educators in the room, remember that all CAIEP events are available for inclusion in your curriculum. Thank you all. Thank you for being such a wonderful group. Have a great rest of your day. Thank you.
Thank you, presenters and hosts alike. This has been a great session.